In this tutorial, we'll review some of the controversies and complexities surrounding post-arrest management. In going through our first case, we'll consider how long to wait after ROSC to consider the ECG findings reliable for interpretation of acute coronary occlusion. We'll then review some of the latest literature informing when emergent or urgent coronary angiography is helpful post-ROSC. And to wrap up this first aliquot, we'll review some of the latest literature informing us about the benefits, or lack thereof, targeted temperature management, and how this has influenced the recent 2023 update to the AHA ACLS guidelines. In the second half, we'll review some complex scenarios to highlight best practices for coding a patient on mechanical circulatory support. In particular, we'll look at how we can optimize pump settings for a patient with a balloon pump, and if and when to start resuscitation for a patient who may be theoretically fully supported by an Impella or LVAD. Our case involves a 45-year-old man who was brought to our hospital after an out-of-hospital VFib arrest. His wife woke up around 4 a.m., noting the patient was making strange noises and funny movements. She grew concerned when he wouldn't wake up, prompting her to call 911 for help. Upon arrival, EMS found the patient to be in ventricular fibrillation and underwent CPR requiring 3 shocks prior to ROSC. He then went back into VFib while en route to the hospital, requiring an additional shock, and then arrested once again upon arrival to the emergency department, requiring an additional 3 shocks to achieve ROSC. There are almost 1 million cardiac arrests every year, with about 400,000 occurring out of the hospital and 400,000 occurring in the hospital. Among out-of-hospital arrests, only about 10% survive their hospitalization, with roughly double that rate for in-hospital arrests, with an even smaller percentage achieving functional status that allows them to be independent in activities of daily living. About 20% of arrests are precipitated by a shockable rhythm, which makes a difference because these arrests have a much higher survival rate, with about 40% surviving to hospital discharge, half of whom maintain a good functional status. Despite advances in medicine and dozens of new trials, survival rates for these arrests have not budged over the years. This was the first ECG obtained for our patient in the emergency department after ROSC. If you were the cardiology fellow responding to this patient, would you activate the cath lab? Yes, of course. It looks like an acute posterior myocardial infarction. Yes, there's evidence of an inferior myocardial infarction in the inferior leads. Or would you say, no, I'd wait 10 to 15 minutes after ROSC and then repeat an EKG after the patient's been better stabilized? Here I'll present some data that suggests waiting 10 to 15 minutes might be reasonable. This trial looked at 370 patients presenting with out-of-hospital cardiac arrests, 84% of whom had an initial shockable rhythm, who underwent coronary angiography. Cardiologists who were blinded to the angiographic outcomes were then asked to review the ECGs and decide if they met STEMI criteria. When results were stratified by time from ROSC to ECG acquisition, we see that ECGs obtained less than 7 minutes from ROSC had nearly a 3-fold increase in false positive interpretations of ACS. Thus, waiting 10 to 15 minutes may be reasonable. In fact, a recent consensus statement released by the AHA in December 2020 cite this trial, emphasizing that metabolic processes such as hyperkalemia and acidemia can cause ECG abnormalities that mimic ischemia, and that when there's ambiguity regarding the post-ROSC ECG, a serial ECG should be performed 30 minutes after ROSC to help guide decisions for emergent coronary angiography. Next, we'll consider when emergent angiography is indicated. Here's our patient's ECG 30 minutes after ROSC. Do you activate the cath lab? Yes, it's guideline recommended. Yes, it seems like the right thing to do. He just had 3 VFib arrests. No, let's wait to see if he recovers. Or no, it doesn't change the outcome. In 2019, the New England Journal published a randomized control trial examining this very question. 522 patients with out-of-hospital cardiac arrests, all of which started with a shockable rhythm, were randomized to get immediate angiography with a mean cath time of 2.3 hours from arrest, versus delayed angiography with a mean cath time of 5 days from the arrest. there was no difference in survival at 90 days, or survival with good neurologic outcomes defined as a CPC less than or equal to 2. They did find that about 20 to 25% of these patients had acute thrombotic occlusion at the time of cath. A similar paper was published in the New England Journal in 2021, this time with about half the cohort having an initial non-shockable rhythm. Once again, no difference was found in survival at 30 days, nor a difference in good neurologic outcome. Interestingly, in this cohort of patients, acute thrombotic occlusion was found in about 40% of patients. Based on these 2 trials and 4 others, the recently updated AHA consensus statement reminds us that in the absence of STEMI, there has been no demonstrated survival benefit for taking these post-arrest patients emergently to the cath lab, but that it's not unreasonable if clinical suspicion is high for ACS based on chest pain or other ECG findings suggestive of acute coronary occlusion. They also remind us that while there are no randomized trials demonstrating survival benefit for emergent angiography for post-Rosc patients with STEMI, based on observational studies, it still retains a Class 1 recommendation. Our patient was taken urgently to the cath lab, where he was found to have triple vessel disease, with chronic total occlusion of his LED, circumflex, and RCA, mostly filled by collaterals off a 75% stenosed ramus. A balloon pump was placed in the cath lab with plan for cabbage evaluation. He remained unresponsive and was found with decerebrate prostrate. So, is targeted temperature management beneficial? The enthusiasm for targeted temperature management started with the 2002 release of 2 New England Journal trials demonstrating improved neurologic outcomes with a strategy of cooling to 33 degrees Celsius versus 37 degrees Celsius for patients with out-of-hospital arrests and initial shockable rhythms. Although the outcomes were statistically significant, these trials were later criticized for being too small and lacking rigorous means for assessing neurological function. In 2013, the New England Journal published a larger randomized control trial, the TTM trial, which included over 900 patients, and examined a strategy of 33 degrees versus 36 degrees Celsius for patients with out-of-hospital arrests, 80% of whom had shockable rhythms. This trial failed to demonstrate a difference in mortality or neurological benefit between the 2 groups. In 2019, the New England Journal published the Hypoxia trial, which looked at a strategy of 33 degrees versus 37 degrees. This time, the patients had non-shockable rhythms and included patients with in-hospital arrests. This time, a nearly 2-fold increase in good neurologic outcomes was reported in the group that was cooled to 33 degrees Celsius. This trial has been criticized, however, for having a fragility index equal to 1, meaning that if just one patient in the trial who had been categorized as having a good neurologic outcome had been moved to the group that had a bad neurological outcome, the reported benefit would no longer be statistically significant. In 2021, the New England Journal published the TTM trial, the largest targeted temperature management trial to date, including almost 2,000 patients, which again showed no neurologic or mortality benefit in cooling patients to 33 degrees Celsius. It did, however, demonstrate a statistically significant increase in hemodynamically significant arrhythmias. With this new data in mind, the AHA's focused update, which was released in December 2023, states, "We recommend all adults who do not follow commands after ROSC, irrespective of arrest location or presenting rhythm, receive treatment that includes a deliberate strategy for temperature control." They emphasize terminology shifting away from targeted temperature management to temperature control, which encompasses hypothermic control, normothermic control, and fever prevention. And they note that the upper limit of temperature control was raised to 37.5 degrees Celsius to reflect findings of no difference between patients being treated with a temperature of 33 degrees Celsius or 37.5 degrees Celsius in the TTM trial. They provide a Class 1 recommendation for selecting and maintaining a constant temperature between 32 and 37 degrees Celsius post-arrest for temperature control, and that hospitals should develop protocols for post-arrest temperature management, but they note that there's insufficient evidence to recommend a specific therapeutic temperature. Active cooling was not necessary for our patient, who arrived to the CCU hypothermic. Unfortunately, not long after arrival, he went back into ventricular fibrillation. Fortunately, he returned to sinus rhythm promptly after one shock, but that might not always be the case. Had he required more than 3 shocks, what would be your next step to help optimize his outcome in the setting of refractory VFib arrest? Would it be head-up CPR, stellate ganglion block, vector change, meaning repositioning the defibrillator pads to an anterior-posterior orientation, double sequential defibrillation, or ECMO? Although there is no right answer per current guidelines at this time, my choice would be for double sequential defibrillation. Double sequential defibrillation refers to the technique of providing rapid sequential shocks via 2 defibrillators with the defibrillation pads placed in 2 different planes, anterior lateral and anterior posterior. A 2002 New England Journal article examined 405 patients with out-of-hospital VT or VF arrests that were refractory to 3 shocks. They found that employing double sequential defibrillation resulted in a nearly 3-fold increase in survival to discharge, along with a 3-fold increase in good neurologic outcomes. This technique was first reported in 1994 by a team of electrophysiologists who found it successful in helping achieve ROSC in patients who developed VFib during routine EP testing refractory to conventional therapy. For those of you who would have activated your ECMO team, this may also be a reasonable option. However, at present, there are no randomized trials studying this in the inpatient population. In 2023, the New England Journal published a study which examined early ECMO for out-of-hospital cardiac arrests, known as the Inception trial, conducted in the Netherlands, which failed to demonstrate a statistically significant improvement in neurological outcomes for those randomized to the early ECMO arm. This study randomized 160 patients with out-of-hospital cardiac arrests with initial shockable rhythms to either early ECMO with a median time from arrest to ECMO initiation of 74 minutes to conventional CPR. In both groups, EMS arrived on the scene within 8 minutes, and patients were transported to the emergency department between 36 and 38 minutes. Unfortunately, patients in the early ECMO arm did not demonstrate improved neurological recovery at 30 days or 6 months. The findings of this trial have not discouraged the writers of the latest AHA consensus statement for the management of patients with cardiac arrest, who recommend early assessment of clinical criteria for ECMO-assisted CPR if ROSC is not achieved after 3 shocks or 10 minutes of CPR with at least 1 shock. They note that the Inception trial, none of the hospitals had established eCPR programs before the onset of the study, and that as such, ECMO success rates were not as high as they could have been, emphasizing a considerably higher time to cannulation than that reported in the Arrest trial, which we'll now briefly review. The Arrest trial, which was about 1/5 the size of the Inception trial, was conducted out of Minneapolis at a hospital with a well-established ECMO program. They found that implementation of early ECMO resulted in a 6-fold increase in survival to hospital discharge among patients with out-of-hospital cardiac arrests with initial shockable rhythms. They reported similar times from arrest to the arrival of EMS as the Inception trial. However, they were able to initiate ECMO about 25 minutes earlier. Part of their success can likely be attributed to the efforts of Dr. Bartos and Dr. Yiannopoulos, who both took ECMO call every day for 2 years to establish expertise in ECMO-CPR, and who are now reporting average needle to cannulation times of about 4 minutes. Their program now has a mobile ECMO team, which allows them to meet their patients halfway to the hospital for even earlier ECMO cannulation. Despite the impressive results reported in this study, and in part due to its small sample size of only 30 patients, it also carries a fragility index of 1, meaning that if only 1 patient in the early ECMO arm with a good outcome ended up having a bad outcome, the results would no longer carry statistical significance. Some of you may have chosen head-up CPR, which was recently reported to improve the odds of good neurologic recovery by 5-fold. The theory behind elevation of the head comes from trying to optimize cerebral perfusion pressure. Cerebral perfusion pressure can be calculated by subtracting the central venous pressure or intracranial pressure from the mean arterial pressure. During a cardiac arrest, blood will stagnate in the jugular veins, resulting in an increase in the central venous pressure. As a result, cerebral perfusion pressure will drop. Of course, during an arrest, the mean arterial pressure will drop as well, and consequently, the cerebral perfusion pressure will now be only a small fraction of what it was pre-arrest. Elevation of the head can assist in blood return to the heart and consequently improve cerebral perfusion pressure. Simultaneous use of an automated chest compression device can help overcome the additional forces of gravity, resulting in a return of cerebral perfusion pressure to near normal levels. This was first studied by placing pigs on a tilt table and inducing ventricular fibrillation for 8 minutes before starting CPR, in either the supine position or the head-up position. They found that through the combined use of head elevation with an automated compression device, cerebral perfusion pressure near normalized. Since that time, a device has been developed called the L-Guard, which combines a device designed to gradually elevate the head with an automated compression device. They found that when the L-Guard was applied to patients in less than 11 minutes, survival with good neurologic outcomes was 6-fold higher. Lastly, some of you may have chosen stellate ganglion block. This technique is known to facilitate suppression of refractory ventricular tachycardia. However, there are no large trials for its implementation at the bedside in an emergency setting. Case reports do, however, exist, such as this one reported by a group of emergency physicians at Mount Sinai. A patient who presented to their emergency department with an anterior STEMI quickly deteriorated into a ventricular fibrillation arrest, which did not terminate after standard or double sequential defibrillation. Thus, an ultrasound-guided stellate ganglion block was performed in the emergency department with prompt Rosc after the next defibrillation, and after 42 minutes of CPR, the patient had sufficient neurological recovery and underwent PCI of his culprit LAD lesion. To recap, we reviewed data from a few randomized control trials that demonstrated head-up CPR and double sequential defibrillation significantly improves neurologic outcomes in patients with refractory arrest. ECMO and stellate ganglion blocks are likely helpful as well, but at the present time, the data for the emergent inpatient setting is lacking. Now, while you are waiting for the nurse to grab you a second defibrillator, you start to wonder if there's anything else you need to consider while coding this patient with a balloon pump. Are there any special changes that should be made to optimize the outcomes in this code? Under most circumstances, the balloon will be set to an ECG trigger, in which the balloon knows to inflate when it sees the peak of a T wave and deflate when it sees the peak of a QRS complex. But during a VT or VF arrest, when there is no clear T wave or QRS complex, the machine may get confused. So which trigger mode would you set the balloon to? Most literature suggests that the pressure mode is the best setting during a cardiac arrest. For example, this article from the Journal of Thoracic Cardiovascular Surgery notes, the intra-aortic balloon pump can complicate the recognition of cardiac arrest in the case of PEA or asystole with an active pacemaker. If the intra-aortic balloon pump has been set to trigger by the electrocardiographic tracing, it will continue to trigger, producing a pulsatile arterial form in the absence of perfusing cardiac output, and that during the cardiac arrest, the intra-aortic balloon pump should be switched to the pressure mode of triggering with a 1-to-1 counter pulsation and maximal augmentation, using the intra-aortic balloon pump for augmentation of the cardiac output generated by CPR, which is echoed by guidance provided by the American Society for the Surgery of Trauma, who note, if a patient on intra-aortic balloon pump has a cardiac arrest, switch the pump to a pressure trigger mode and decrease augmentation to 50%. This is also supported by the Journal of Critical Care Nursing, who suggests changing the trigger mode for the intra-aortic balloon pump from ECG to arterial. But not everyone agrees. In 2008, a cardiologist in Turkey, Dr. Aslanger, described the case of a 74-year-old woman who was admitted with an NSTEMI whose course was complicated by a PEA arrest during cardiac cath. After 20 minutes of CPR, the patient was found to be in asystole. The physician then made the decision to totally occlude the aorta using a balloon pump, which resulted in return of spontaneous circulation after an additional 30 seconds of CPR. He notes that aortic occlusion during CPR can occlude the unnecessary part of the circulation and divert blood to the heart and brain, and proposes that for patients who develop cardiac arrest during cardiac catheterization, they may be resuscitated successfully by using intra-aortic balloon occlusion to increase cardiocerebral perfusion. But now let's imagine that rather than a balloon pump, an Impella was supporting this patient when he was found pulseless with this unstable rhythm. With the following tracing on the Impella monitor, should CPR be initiated in this setting? 4 important questions to consider before starting CPR are: how much cardiac output does the patient require? Is the Impella matching that cardiac output? Is the Impella in the right position? And should you make any changes to pump settings? First, let's consider how much cardiac output the patient needs. Remembering that cardiac index is equal to cardiac output divided by body surface area, we can see that the cardiac output equals cardiac index multiplied by body surface area. Thus, for a small patient with a BSA of 1.4, to maintain a reasonable cardiac index of 2.2, their cardiac output would have to be 3.0. On the other hand, a larger patient with, for example, a BSA of 2.7 would require double the cardiac output to maintain the same cardiac index. In this hypothetical scenario, if the Impella was in a small patient with a BSA of, say, 1.4, they would need 3 liters of cardiac output to maintain a cardiac index of 2.2. Looking at the Impella monitor, we see that the cardiac output is 3.3. Thus, it should be providing sufficient cardiac output to perfuse the patient, even if their heart is not pumping at all. Next, we must consider if the Impella is in the correct position to deliver the reported cardiac output. Here we see relatively flat waveforms in the green motor current tracing and the red placement signal tracing. The red placement signal tracing reflects true arterial pressure detected by a fiber optic sensor in the Impella catheter. The green motor current tracing reflects the amount of energy and flow through the cannula. When the Impella is properly placed, the motor current will be pulsatile, with peaks when the aortic valve is open and there is more energy and flow, and valleys when the aortic valve is closed and there is less energy and flow. When the Impella drifts out of position, the motor current will be flat because the aortic valve is no longer creating a pressure gradient across the cannula. A flat motor current, coupled with a ventricularized waveform pattern, indicates the Impella has slipped too deep into the ventricle, whereas a flat motor current coupled with an aortic waveform pattern indicates the Impella has slipped too far into the aorta. Although a flat motor current waveform should at least make you consider if the Impella is improperly positioned, there is one important situation where a flat waveform can indicate appropriate pump position and function. And that's the waveform we see at the upper left, where the aortic placement signal and motor signal currents are relatively flat. This situation can indicate a well-functioning Impella and a very weak heart. If the heart is barely pumping, you may not see much pulsatility on the aortic waveform, and consequently, there may not be observable pulsatility on the motor current waveform. This is actually an optimal condition for Impella efficiency, which leverages the increased preload in the left ventricle and reduced afterload in the aorta to deliver blood more efficiently through the cannula. We've now seen that for this smaller patient, 3 liters of cardiac output is needed to maintain a physiologic cardiac index, and that the Impella in this scenario is matching that level of support. We also saw that the Impella is in the right position and operating efficiently as indicated by the relatively flat aortic placement and motor current waveforms. Finally, we must ask ourselves if CPR is indicated in this setting. For guidance in this situation, we can turn to the 2022 Handbook for Mechanical Circulatory Support published by the European Society of Cardiology, which has a chapter on Impella troubleshooting and resuscitation. They remind us that CPR should be performed based on loss of perfusion rather than on ECG findings or flattening of the arterial waveform, since the device can often maintain adequate perfusion pressures despite ventricular tachycardia. So in the small patient we just reviewed, jumping straight to CPR would not necessarily be indicated. Let's now imagine, however, that we're dealing with a much larger patient who would need 6 liters of cardiac output to maintain a cardiac index of 2.2. If the Impella is only providing 3.3 liters of additional cardiac output, should you start CPR now? We know that the ESC handbook recommends looking for signs of reduced perfusion, so how can we tell if our patient is being adequately perfused? In 2017, the American Heart Association published an algorithm to help guide when to start CPR in patients with mechanical circulatory support. Although it is focused more on patients with left ventricular assist devices, it seems it should be applicable to patients with Impellas as well. Here they consider a MAP of less than 50 or an end-tidal CO2 less than 20, if the patient's intubated, reasonable indicators of poor perfusion that should prompt you to consider initiating CPR, even for patients with well-functioning mechanical support. Finally, the ESC handbook also recommends that if you do initiate CPR on a patient with an Impella, to reduce the P level to P2 to minimize damage to cardiac structures, and to check Impella position with an echocardiogram after Rosc to ensure the Impella was not dislodged during CPR. Returning now to our patient, post-Rosc, we once again find him with fixed and dilated pupils, myoclonic jerking, and decerebrate posturing. As you leave his room, you run into his concerned wife in the hallway who asks, "Is he going to be all right?" You think to yourself, absent pupillary reflexes are a pretty poor prognostic sign. Myoclonic jerking is also a pretty poor prognostic sign. Decerebrate posturing is a poor prognostic sign as well, or I should really wait at least 72 hours before I attempt to neuroprognosticate. According to the most up-to-date neuroprognostication guidelines from the American Academy of Neurology, which were published in 2006, evidence of myoclonus or status epilepticus on day 1 indicate poor prognosis with a false positive rate of 0%, as do absence of pupil or corneal reflexes on day 3. By 2014, the notion of using clinical exam findings from the first day had faded, with the European Society of Intensive Care Medicine providing an updated algorithm that emphasized starting neuroprognostication no earlier than 72 hours post-arrest. Once again, the absence of pupillary and corneal reflexes reflected a poor prognosis. However, this time, false positive rates were acknowledged to be slightly higher at less than 5%. The importance of waiting 72 hours was re-emphasized in the 2020 AHA guidelines for cardiopulmonary resuscitation, along with using quantitative pupillometry with a pupillometer when possible. The 72-hour delay was upheld in the 2021 update to the European Society of Intensive Care Medicine recommendations, as well as the 2023 guidelines for neuroprognostication in comatose adult survivors of cardiac arrest, put forth by the Society of Neurocritical Care. Despite current guidelines recommending delaying withdrawal of life-sustaining therapies for at least 72 hours after Rosc, withdrawal before 72 hours is common. In a secondary analysis of the ROC Prime trial, which studied over 16,000 patients with out-of-hospital cardiac arrests across 9 centers, it was found that 25% survived a hospital arrival. Of the 65% of patients who did not survive their hospitalization, 59% died due to withdrawal of life-sustaining therapy due to a perceived poor prognosis, the majority of whom, 56%, had withdrawal of life support less than 72 hours from Rosc. It's important to note that in this subpopulation of individuals, withdrawal of life-sustaining therapy was initiated due to perceived poor prognostic neurological outcomes and not due to medical instability, brain death, or non-neurologic issues. Moreover, a 2022 study from Taiwan revealed that out of 2,500 subjects with out-of-hospital cardiac arrests, 25% of those who survived with good neurologic outcome did not reveal signs of conscious activity until more than 3 days after Rosc, with as many as 10% not showing conscious activity until 7 days post-Rosc. With these findings in mind, there is now growing recognition and conversation about the influence of the self-fulfilling prophecy bias within the neurocritical care community. And this is particularly important as our understanding of the mechanisms of cerebral injury in the setting of hypoxia continue to evolve. If you were to Google cerebral hypoxia, you'll find lots of credible references stating that brain cells begin to die within 5 minutes of low oxygen. But in 2019, a team at Yale made an interesting discovery while studying the brains of 32 pigs that had been decapitated for meat processing. They found that even after the brains had been left out at room temperature for 4 hours, if they were infused with a blood-like substance termed organ X, they started to show signs of life again after 6 to 10 hours, which reinforced our growing understanding that it may take much longer than 5 to 10 minutes of hypoxia for brain cells to die. And as crazy as this sounds, it's true. And likely few appreciate this more than Dr. Will Flannery, known to many as Dr. Glaucomflecken, who himself sustained a prolonged period of cerebral hypoxia during the height of the COVID pandemic in May 2020. In the early hours of the morning on May 11, 2020, Dr. Flannery's wife awoke to him making strange noises and movements, which she later learned were agonal breath sounds. She grew increasingly concerned as she was unable to wake him, prompting her to call 911. EMS then coached her through CPR, which she had to perform on the bed for 10 minutes before EMS arrived. Upon EMS arrival, he was found to be in ventricular fibrillation. Resuscitation efforts continued for an additional 20 minutes, and he required 5 shocks before ROSC was achieved. Despite his prolonged downtime and suboptimal environment for resuscitation, he was back to posting witty videos on his TikTok page 6 days after the event. And was evidently discharged with a life vest.
As I walk through the valley of the shadow of death, I take a look at my life and realize there's nothing left. Cause I've been blasting and laughing so long that even my mama thinks that my mind is gone. But I ain't never crossed a man that didn't deserve it. Me be treated like a punk, you know that's unheard of. You better watch how you're talking and where you're walking, or you and your homies might be lying in chalk. I really hate the trip, but I gotta low. As they croak, I see my...
Although our patient didn't go on to making viral TikTok videos, he did start following commands on hospital day 9 and was extubated on day 10, cracking jokes with our team. 4 days later, he underwent cabbage, and like Dr. Flannery, was discharged with a life vest 4 days later. And although this may sound like a win, it's important to remember that post-arrest management doesn't end when the patient leaves the hospital. A recent scientific statement by the American Heart Association on recovery and survivorship after cardiac arrest acknowledges that the physical, cognitive, and emotional effects of surviving cardiac arrest may linger for months or years, and that they often extend beyond the individual patient to their family members or caregivers, with a high percentage of co-survivors experiencing fear, anxiety, and post-traumatic stress syndrome. One study found that clinically significant post-traumatic stress may actually be higher in co-survivors, which may be related to the unique trauma associated with witnessing the event. And this has broader implications for the patient, as it's often the co-survivors who are coordinating the patient's medical care, including ICD or other advanced heart support device management, while struggling to meet their own health needs and manage their psychological distress. With this in mind, one of the lead authors of the paper, Dr. Agarwal, created the website ourheartsite.com as a resource hub for survivors of co-survivors of cardiac arrest, and is hoping to demonstrate its efficacy in reducing psychological distress and caregiver burden in a trial titled Resurface, which will use the website to deliver curated information at distinct time points in the post-arrest period. And although there are currently no formal guidelines to inform our approach to co-survivors, an unofficial guide was recently authored by Kristen Flannery, known to many as Lady Glaucomflecken, who is now one of the most well-known advocates for co-survivors of cardiac arrest. Of the 10 recommendations outlined, she highlights the 4th in a separate post titled, How to Be a Compassionate Clinician in One Easy Step, where she reminds clinicians the importance of checking in on the family members of the patient and simply asking, "How are you doing?" In summary, we saw that it may be reasonable to wait 10 to 15 minutes after ROSC to determine if ECG findings warrant emergent activation of the cath lab. We were reminded that at present, data has not demonstrated a significant mortality benefit for immediate coronary angiography after shockable arrests in the absence of ECG findings known to reflect acute coronary syndrome. We reviewed the latest literature informing us about post-Rosc temperature management and saw that while this remains an area of active investigation, there seems to be consensus that fever should be actively avoided. We saw that if we find ourselves in the position of resuscitating a patient with a balloon pump, most would recommend switching the trigger mode to pressure sensing. And that if your patient has an Impella or an LVAD, which is providing full support to the patient, CPR can often be avoided unless the end tidal CO2 drops below 20 or MAP below 50. We saw that in the setting of a refractory VT or VF arrest, unresponsive to 3 conventional shocks, double sequential defibrillation improves the odds of good neurologic outcome by over 2-fold, and that head-up CPR technique improves the odds of good neurologic outcome by greater than 5-fold. Finally, we were reminded that in most circumstances, we should wait at least 72 hours before attempting neuroprognostication, as the self-fulfilling prophecy bias seems to play a much more significant role in patient outcomes than previously recognized, and that we're living through an exciting time as our understanding of cerebral recovery continues to evolve.